بقى كل ممكن في العالم. هنتقابل ان شاء الله الساعه 7 ان شاء الله طيب في المكان. So the resistance of this habit in children lead to voiding dysfunction. However, children with voiding dysfunction may make this voiding dysfunction can be assigned underlying pathology that need treatment later on. Actually, our renal tract has two main functions: storage and storage adequate volume of urine at low pressure with no leakage, and limiting that is voluntary, efficient, complete with and under low pressure also. As we said before, the our renal tract in children differs from that in adults in many aspects. The most important in our topics today that there is increased voiding frequency during infancy, and the voiding frequency decreases with advancing in age, till reaching the frequency as above by age 20 years. Also, there is high voiding pressure, especially during the first year of life, then decrease in later on. Also, there is some intraocular sphincter dysmenorrhea or discoordination in infants. Also, toilet training in children starts by the age of 2 to 3 years, and by the age of 4 years, almost all children should be toilet trained and quality. But there are many requirements for this to achieve continence in children. The most important requirements include progressive increase in functional capacity of the bladder, maturation of mental control over the external muscular sphincter, and development of direct control over bladder sphincter complex, which includes the bladder, the detrusor, and the sphincter coordination, also intact nervous system. As we know, there is CNS micturition center, which is located in the bones, and this micturition center exerts voluntary control over the spinal center. The spinal centers are either sympathetic or parasympathetic and somatic. The sympathetic supply to the bladder, which via the hypogastric nerve, and the parasympathetic via the pelvic nerve, and the pudendal nerve exerts voluntary control over the external visceral sphincter. Actually, the bowel and the bladder, as we know, as we will discuss later, the bowel and the bladder are associated with each other because they are developmentally have the same origin during development. So, the usual consequence of bowel and the bladder control include nocturnal bowel control, followed by diurnal bowel control, followed by diurnal urinary control, and lastly nocturnal control. So, as we said, the bowel and the bladder may affect each other. and this is the most important cause of organ dysfunction in those children. The lower urinary tract is tied to the lower GID tract as both have the same evolutionary origin, and up to 6 weeks of gestation, both the urogenital sinus and hind gut open into common providers. Also, as you see here, that if the rectum is distinguished with from fetal mother, this may compress the bladder neck and leading to disposal dysfunction. This is the normal stool, soft stool, associated with normal anus, competent anus. While when there is this hard stool, the soft stool above it leads around the hard stool, leading to fecal soiling of the underground, which is called necrosis. So, large fecal infection may induce mucosal instability. That is what is called dysfunction elimination syndrome. The meaning of dysfunction elimination syndrome is that dysfunction of one, either the lower or the bladder, may affect the other. There are two main types of dysfunction elimination syndrome. Disorder of feeling, which is associated with overactive bladder and associated with fecal infection and rectal extension. Dysfunction of eating, which is associated with overactive pelvic floor during void. And this also leads to non-relaxation of the pubic and painful defecation. So, this dysfunction elimination syndrome, when present, usually associated with multiple urinary problems, as very little reflux, UTI, and incontinence. So, dysfunction elimination syndrome should be treated first before correction of these urologic problems. Then, the bladder sphincter dysfunction during the bladder filling, as we said, include overactive bladder. That means overactive bladder means sudden severe desire to micturate that is difficult to negate. May be associated with or without urgent incontinence. If there is leakage, this is called urgent incontinence, which is more common in female, and often those children seen with more malnourishment. That includes Vincent Kersey, as this picture, or holding maneuver, and lastly, those children have often to be in a squatting position with the heel in the urine. Functional urinary incontinence, which means involuntary loss of urine due to failure to control of the bladder sphincter complex. The amount of leakage in those children is usually very small, and this condition often seen in older girls that play sports, and it is self-limited disease and often disappears at the age of puberty. Legal incontinence. The cause of legal incontinence, which means incontinence during giggling or laughing, is unknown. The actual cause is unknown. And during giggling, large volume of urine may leak and may empty the bladder. While bladder sphincter dysfunction during the bladder emptying have nearly 5 flaws. Either staccato voiding, which means bursts of pelvic floor activity during voiding, leading to interrupted urine and high liver. And this is the flow curve of staccato voiding, interrupted stream. While vaginative voiding, which is due to causal activity that lead to infrequent and complete emptying of the bladder, and the flow curve in those children have vaginative flow reaching to the baseline, then reaching to the Tmax, then reaching to the baseline again, and those children may be seen with picture of overflow incontinence. There is a bladder syndrome, which is a modest form of voiding dysfunction As we see here, large hydrotonic bladder with frequent voiding and both urine stream, and abdominal stability should be elicited to imitate this bladder, and this is the modest form of voiding dysfunction. The severe form of voiding dysfunction, which is known as the Helmy syndrome, or the other term non-neurogenic bladder, has the picture of neuropathic bladder, but in absence of any neurogenic disorder. Those children have overactive pelvic floor and sphincter, severe form of voiding dysfunction, and often have overflow incontinence, and often get high UTI and recover UTI. And about 2/3 of these children have associated hydronephrosis. And as we see in the picture, reflux is a common association in nearly 1/2 of those patients. While the other problem is the Schwartz syndrome, which is autosomal recessive inheritance disorder with gene in chromosome 10, those children, as you see here in the picture, have dysfunction voiding and painful or crying expression as seen here with smile. And those children, 1/2 of them may be presented with end-stage kidney disease. The fifth letter of dysfunction during the mother kidney is the post-voiding urethra, which is common in girls. Usually, this is vaginal leakage due to radial adhesion, and often diagnosed with refugee. And for treatment of this case, we should encourage girls to voiding with size above and with opening of the labial urine void. So, when you face a case of voiding dysfunction, there are important topics for evaluation of those patients. Often those children present after toilet training, except if there is associated urinary tract infection or associated reflux. Can be diagnosed before the age of toilet training, which is 4 years old. By history taking, we should exclude any case, we should rule out the symptoms of urologic abnormalities as painful urination or micturition and benign or vaginal pain and discharge. Medical and surgical risk of course is important, including blood pressure, include the renal scarring from associated reflux, which is common in those children. Voiding diarrhea and regarding the storage and voiding and the frequency is important also to diagnose those cases. Also, bowel history is important, and in most cases of voiding dysfunction, the family history regarding the bowel habits is very poor, and you should know and ask them for the associated symptoms of constipation or measles or whatever to exclude as a cause of voiding dysfunction, which is the most common cause. During the examination, general with the gait and movement of the child, abdominal examination as the bladder may be palpable with hard either out or there is palpable fecal matter of the nose. Back examination, which is the very important to exclude your underlying neurological disease. The back examination is very important in those children. As we see here, there is asymmetry of the nuclear clips. There is one clip and on the other hand there is two clips. And this may be a sign of underlying spinal cord disease. The other is hair cuff. Hair cuff on the left also may be hidden underlying neurological disease. Also, dimpling at the back may be associated with underlying neurological disease. So, back examination in patient with voiding dysfunction is very crucial. Examination of the external genital. As we said before, post-voiding developing in young may be due to labial lesion. So, examination of the labia of the lung ureters is important to exclude labial lesion, and this may be the cause of this boiling dysfunction. While in boys, it is very important to note in the risk associated meatal stenosis to them, as meatal stenosis is the very common cause in children and boys with boiling dysfunction. Also, to assess the state of circumcision and if there is associated illness. Regarding the laboratory investigation, urine analysis to exclude bacteria and zoria or bacteria, serum and urinary osmolality in cases of bacterial disease. Imaging studies by ultrasound to assess the upper tract and the thickness of the bladder wall and the VVR. This usually is important to rule out reflux and give us idea about the capacity of the bladder and if there is associated bladder wall irregularity, and it is important in girls with boiling dysfunction to know that there is what is called spinal tubular. As you see here, there is final bladder followed by contraction at the bladder neck. Then there is gradual tapering of the urethra, which is the sign of boiling dysfunction in this area. Also, to assess the VVR in the post-boiling defend, leg X-ray and MRI is only needed in the restorations of underlying urologic cause. Urodynamic usually not indicated unless there is resistance to treatment with resistant to boiling dysfunction, and these are the normal values of urodynamic evaluation in shape. So, when you face a case of boiling dysfunction with exclusion of neuropathic element, there are several lines to treatment, but the aim of treatment is to protect the upper tract, improve the lower renal tract function, improvement of urinary incontinence, and improvement of patient's quality of life. So, first we start with behavioral modification and the standard urotherapy, which include bladder training and boiling behavior, which is very important to know the boiling habits of the children and to know the volume of boiling urine and the frequency of boiling, which is very important in those children. As the maybe in basic bladder syndrome, the boiling mean over the 24-hour maybe less than 3 points per day, and this may be a sign of basic bladder syndrome or infrequent boiling in those children. So it is also important to educate the parents about the disease, and it is usually self-limiting disease, but it requires some rehabilitation of the family and the child. Changing the bowel habit, which is important for having different dietary fibers, which is important to maintain regular stool. Then pelvic floor muscle training and biofeedback, which is not the first line of treatment, but it is reported that it means self-conception of mucosal contraction and pelvic floor relaxation. As we said before, the bowel is the most common cause of constipation, is the most common one of the most common causes of boiling dysfunction. So, those children may need regular cleanup or maintaining of regular soft and maintaining of regular soft stool by adequate dietary fiber. Medication needed, which is mostly anticholinergic in severe cases. After failure of behavioral modification, we may add anticholinergic, which is an oxybutynin is the gold standard in those children for overactive bladder. Also newly important drugs like urabinol, which is sympathomagnetic beta-3 agonist, acting on the overactive bladder, but it is more formulated in children less than 10 years. Alpha-adrenergic blockers may be needed if there is evidence of bladder neck dysfunction or hyperactive bladder neck. Tricyclic antidepressant may be used to increase storage capacity and have the same action as anticoagulation. CRC. As we said before, the lazy bladder syndrome or infrequent voidance may be voided less than 3 times in 24 hours or may stay without voiding for more than 12 hours. Those children may need to evacuate the bladder with clean intermittent pasteurization every 4 hours. Also, this CIC may allow for bladder cleaning and improve the mucosa contractility by regular evacuating the bladder and regaining the bladder contractility in time and frequent ways. Lastly, surgery is generally indicated in cases of avoiding dysfunction unlike neuropathic bladder. It is recommended to do augmentation cystoplasty with observed outlet in cases with severe form, which is a Helmy syndrome, which is non-neurogenic dysfunction, or with the risk of high voiding depression that may deteriorate the upper limb. So, this is a summary of the approach to voiding dysfunction. In a child with suspected voiding dysfunction and fails to deal with daytime voiding and recovered UTI or vaginal reflux, we should rule out organic pathology by history, physical examination, urine analysis, and ultrasound BCG. If we rule out inorganic cause, we can maintain the child contamination level voiding level with treatment of constipation, antibiotic prophylaxis if there is associated with blood, and if there is associated with reflux, and if there is improvement, we can follow them up. If there is no improvement and there is resistance, we can shift to urinary study, which is well indicated in those children. If there is pregnancy involved, we can maintain the child on anticoagulation and voiding. If there is bladder dysfunction, bladder dysfunction, biofeedback and time voiding may have a role, and if there is lazy bladder syndrome, we can maintain them on CRC and time voiding. And if there is normal study, we should assess the motivation of the family and consider psychological evaluation. نكمل ده سيرته ده يعني ده سيرته يعني ده خاص يعني ده شيء عجبك For definition of continual analysis, there is not two classification as according to International Children's Continence Society. This is either primary or secondary, monosymptomatic or polysymptomatic. Primary continual analysis that means that these children have never been derived for a period of more than 6 months. While secondary continual analysis, if those children have been derived for at least 6 months, prior to being in incontinence at night. Monosymptomatic continual analysis may describe being weakened in children with no daytime voiding dysfunction. While polysymptomatic continual analysis is that is associated with urinary voiding dysfunction. Regarding the epidemiology of continual analysis, the majority of cases are primary continual analysis, maybe 85% of cases are continual analysis are primary. Also, it is more common in male, and continual analysis has more activity that in short for this. 15% of children at the age of 5 years have continual analysis, and 15% have associated analysis, and 15% become the right year. Also, 15% have secondary nuclear analysis, and 15% have daytime symptoms. The incidence increased to 5% by the age of 10 years. So, at the age of 5 years, the incidence of nuclear analysis is 15%, and increased to 5% by the age of 10 years. And the incidence also decreased at the age of 15 to 1% in cases of children with under 15 years. Causes of nocturnal analysis are many, but the most important concept is nocturnal urinary. Nocturnal urinary is due to abnormals in circadian rhythm of antidiabetic hormone. So urine production during sleep exceeds the normal capacity. So those children often get wet after going to sleep. يعني حد بيتكلم انجليزي يا جماعه؟ كله عربي. يعني تيجي حضرتك الام تشتكي لك تقول لها ان هو بعد ما قبل ما ينام ده تلاقيه يقول لك اقعد ادخله. وبعد ما ينام تصحيه بساعتين تقول لك بروح اصحيه بعدها بساعه بلاقيه عنده. يبقى مسلم لازم يفكر في الدكتور من جديد. مسلم. The second is reduced function of blood capacity during sleep as 75% have dysfunctional voiding during daytime. Arousal failure may be due to high arousal threshold or the presence of spontaneous uninhibited bladder contraction. So it is autosomal dominant disease, inherited from 13, and we will ask the parents if they have been wet during childhood. If both parents are wet during their childhood, the incidence will be 75% of their office when that will be right. If one parent only is wet during childhood, the incidence decreases to 45%. Actually, the workup of nutritional diseases didn't differ from that of any dysfunction. It's the same. And taking the history, laboratory investigation, and the biological investigation as the avoiding dysfunction. The same as avoiding dysfunction. But in history taking, we should know that whether this is primary or secondary, monosymptomatic or polysymptomatic, daytime and night, day and night, if the child is sleep at the daytime, or just only at the night time. The boiling and leakage, as we said, we should know that boiling amount and the frequency motivation of the child with fluid, and if it is associated with lower relevant symptoms, and those children should be toilet free. Family history, as we said, as the best inherited form of urinary disease. Also, social problems for psychological problems and stress for the child. And also history of private duration and management of those children. For management of urinary disease, it does not differ more from that of voiding dysfunction, but we should know that there is no success and there is no urinary awareness before the age of 5 years. No success before the age of 5 years. So if there is a child in the fourth year of life, there is no assessment of urinary disease until become older than 5 years. Observation and assurance of the parents, as we said, if a child is younger than 5 years and says living in the school and students and youth. Also, behavioral modification as in the boiling dysfunction or double boiling, double boiling, and boiling glaring and encourage exercise. Vitamin. The idea of this vitamin is a device. This device is fixed to the undergarments or the couplets of the bed. And so if the child is getting, start to get wet, this alarm is working. Once there is a drop of urine, this alarm is working and it woke up the child. But it requires motivated child and family. Because if the child, because after this alarm working, the child should be taken off from the bed and go to the bathroom. This is one of the most successful treatment options for urinary diseases with success rate ranging from 60 to 100% in most series, and for evaluation of the effectiveness of this alarm therapy, this is the initial success, which means that a minimum of 2 weeks of dry nights within 16 weeks of therapy. Relapse, which means that 2 week nights in 2 weeks. continued success with no relapse within 6 months after initial success. Complete success if there is no relapse within 2 years after initial success. Examination. The role of anticholinergic in urinary diseases is unclear, disappointing in urinary diseases. But behavioral modification is the most important condition in even more than the water. Antidepressant will elicit 40% and improving elicit in 20%, and the dose is 25 mg younger than 8 years and 50 mg for older children, and this taken once daily before going to bed. Also, this medicine has been developed in cases of urinary biliruria and should not be the first line of treatment. As we said, that behavioral modification is the most important, and the dose is 20 to 40 micrograms of intranasal steroid or 200 to 40 micrograms of use. And the most important side effect of this medicine that should be taken in mind, that may cause hyponatremia all over the world and may be used to see. Thank you. After that,